All right, so next we have someone who has been described as the godfather of infectious diseases pharmacy in Australia. It's Matt Rawlins. Matt learned his ID, or obtained his ID expertise from some training in the UK, and has brought that back to Australia and shared it widely with many, including myself, which I'm most grateful. He's the ID pharmacist at Fiona Stanley Hospital and has been largely responsible for the OPAT guidance that's coming through in the latest edition of the therapeutic guidelines. And so now you know who it is. Any hate mail can be directed towards him. But no, it's an absolute pleasure to have him here, straight off the plane from Sri Lanka, and I'm sure that's another story in itself. So welcome, Matt.
Thanks, Jason. Yeah, I am straight off the plane from Sri Lanka, and I'm sorry I missed some of the presentations this morning, but you wouldn't have wanted to have seen me this morning. So, arrived at 6:15. So I'm going to go through some of the interesting things that we found when we were reviewing this topic for the next version of the therapeutic guidelines. First of all, a quick reference to the various OPAT models, very quick because you're all experts. A little bit on the various state guidelines and some reinforced with some odd papers here and there. And then I'm going to have a few slides on controversies that we encountered during the therapeutic guidelines, and then a very brief conclusion. So as you all know, there were IDSA OPAT guidelines published in 2018. Actually, I'll just go back and just quickly say that we are going to call this COPAT. So that's CalPAT without the W. In the next guidelines, and really I'll say a little bit more about that, but certain institutions and regions are very wedded to whether they're using an OPAT model or a HIF model. We wanted to try and encapsulate, so this is community-based parenteral antimicrobial therapy. So this was a group decision on the in the expert advisory group. So there's three basic models of OPAT delivery, as described in the IDSA guidelines. Home-based is most common in Australia, but there are also references to various infusion centres and skilled nursing facilities. And the other thing is, as we've heard from the last two speakers I've heard speak, and undoubtedly from all those before, was that antimicrobial stewardship features heavily in all recent guidelines. And one thing that sort of always has struck me with OPAT, HIF, COPAT is the use of unnecessarily broad or inferior antibiotics for convenience reasons. So drugs like ceftriaxone or ticaplanin, which are not particularly good anti-staphylococcal agents, and are often used for convenience reasons because of once daily administration. And as also you'll see from one paper later on, when people are referred to a HIF, OPAT, COPAT service, they may end up, if there's not good governance, receiving unnecessarily prolonged IV antibiotics. So this is our the main model here in Australia, but having with the proviso that there's self-administration. Some people go once or twice daily. We primarily in our state provide a once daily service. Rather than twice daily, and that's purely usually for cost and resourcing. So just going to pick through a couple of statewide guidelines. So there's a HIF guideline in Queensland from a couple of years back. Patients are considered inpatients. Funding is by the activity-based funding model, including consumables, clinical services, investigations, the antibiotics and other drugs and equipment. Clinical governance can be either by the inpatient admitting team, whether that's ED, a nurse practitioner, an inpatient senior authorised medical officer, or there can be transfer from the admitting team to a HIF authorised practitioner or another practitioner who is authorised to perform HIF. And then there are combination clinical governance models, and there is reference to the principles of antimicrobial stewardship. There's also public-private partnership with Silver Chain, Blue Care, partnering with the hospital health services to increase HIF delivery statewide. And certainly the Silver Chain thing is something that we've, or several of our large institutions in WA, including my own, have moved to Silver Chain provision of nursing care rather than hospital-employed HIF nurses. There was this paper from a few years back which described 5 sites in southern Queensland, and this is the self-administration model which you were referring to, Pauline. So ACES, which is Alternative Site Infusion Service, and really training is provided at the bedside mainly to the patient or to the carer prior to discharge. But there is the provision for nurse delivery if patients or carers are unable. And this limits the nursing visitations. And this paper was mostly looking at bone and joint infections. There's also a couple of hospital in the nursing home interventions reported in the literature. So this one compared Royal Brisbane Women's and Women's Hospital, which is Jason's institution, I believe, versus a Logan Hospital control, whereas an ED nurse led an intervention to manage more residents in residential aged care facility to avoid ED and hospital admission. So patients could either be referred directly before they even made it to the ED, or come from the ED as hospital inpatients. And this, there was support provided for residential aged care facility staff and GPs, and it was primarily run by an ED senior nurse with geriatric medicine experience. And this role involved coordinating patient transfer from the ED or ward, and was shown to reduce ED presentations and hospital admissions. But it was an in-hours service, as in 5 days a week, standard working hours. In South Australia, they also have their own OPAT or HIF guideline, and there's one recent paper where from Flinders Hospital, where referral is made by the managing team, assessment is done by the HIF nurse, drugs are either made in-house or via private external suppliers, weekly lab tests, all pretty standard, but the governance outside Flinders Medical Centre catchment was assigned to GP services and community HIF providers. In New South Wales, it's an admitted service, so a virtual ward. In the HIF guideline, activity-based funding. So there are various models. There's a standalone HIF team, which is obviously formed specifically for HIF care. multidisciplinary, employed by the hospital district, and they're either based in an acute facility or primary or community setting. The HIF, there's also provision for a HIF integrated team where there's a mix of hospital and community providers. So this sort of is more applicable in the rural setting. And acute care nursing staff can provide 24-hour care in dedicated clinical areas off the inpatient unit or the ED. In terms of clinical governance, and this was something that we wanted to be very strong on in the next version of the TG, was defining who was going to have clinical governance for the patient. It doesn't really matter as long as it's well defined, but there's provision for, in these recent guidelines, paediatricians, staff specialists, BMOs, GPs, nurse practitioners, daily clinical review, multidisciplinary team review once or twice weekly, self-administration is possible, and there is strong reference to antimicrobial stewardship principles. So this paper from Western Sydney primarily looked at treatment of skin and skin structure infections, bone and joint infections. There's an outreach service with a nurse unit manager, ID physicians and pharmacists. Nurses administer at home. Interestingly, IVDU were excluded from this paper, and I'll say a bit more about that shortly, because it is something that it appears that some people are a bit stronger on not injecting drug users than others. And an on-call ID consultant basically made the decision to either accept, reject the patient, or ask for a formal review when the referral was made to the HIT service. PICC lines were used for greater than 6 days of therapy, otherwise peripheral intravenous cannulae changed every 72 hours. Victorian HIT guidelines, there's been sort of a number of things published since this, but as far as I know, this is the last formal guideline that's been published. So HIT is described as an alternative to admission or providing earlier relocation of the patient, staffed by dedicated staff. Employees may be shared with other health service providers or contractors. It's activity-based funding with a virtual HIT ward, virtual inpatient ward, and patient selection and medical governance as defined. In Barwon Health, there was a series of 68 cases over pretty much a 10-year period, reviewed. There were HIT clinical nurses, ID physicians and registrar, looking at infective endocarditis, the treatment of, but again, absence of injecting drug users. And the patients were reviewed daily by nurses and weekly at hospital and clinic by the ID team. Paediatric study, which at the time, I'm not sure if this is still the case, Royal Children's Hospital Melbourne was described as the largest paediatric HIT program in Australia. A significant proportion were under 1 year old, particularly looking again at the CF and UTI. As seems to be common in paediatric models, there's less ID formal involvement, and it's certainly the case in our state as well. And it's normally run by a paediatrician, medical registrar, and nursing and physio. ID only involved at team's request, and this study actually resulted in improved ID oversight, as in a change in practice of all patients, but the ultimate decisions stayed with the team. The HITH Reg became responsible for TDM, and we certainly get a lot of questions for our infective endocarditis with gentamicin TDM. I mean, I think it's pretty easy, but you know, people seem to struggle with it, as in for synergy, and also resulted in a pharmacist business case to join the team. Another residential aged care facility, so this was HITH care provided 24 hours a day, 7 days a week in nursing homes, particularly the now defunct category of nursing home associated pneumonia, where a complete service was provided, including oxygen, antibiotics, fluid, pathology, mobile x-ray, and this model allowed patients to be, which is, as we all know, sometimes much more appropriate, that patients are managed in the nursing home rather than being admitted to an acute hospital, particularly in accordance with their own wishes. Medical staff visit daily, nursing once or twice a day. And interestingly, in this paper, those in the residential care facility were on IV antibiotics longer than double the length of time versus those the controlled group in the hospital. So they were slower to switch from IV to oral antibiotics. In WA, we've been taken over to a large extent in terms of Silver Chain has the contract for providing HITH. We actually had to change our name from HITH because we no longer employed HITH nurses, and we had to call ourselves IDAC, which is Infectious Diseases Ambulatory Care. Every time we use the word HITH, they would, I don't know if you've ever been in meetings when they have the managers car park things. You HITH, no, we're car parking that. You're not allowed to mention it again, and it gets put in the corner of the whiteboard, and that's car park. So we came up with another name. But one of our major hospitals still employs HITH nurses and is certainly happy to be doing so. So interestingly, on the Silver Chain nursing contract, no one was ever allowed to see the contract, and it turns out after 3 years, it turned out that they were supposed to be paying for all the medications. Of course, it was too late for us to go back and claim all the 3 years' worth of antibiotics on a very busy HITH, OPAT, COPAT service. Governance by ID physicians. One of our private hospitals, which has several, St John of God, has several campuses, they have maintained a HITH service as well. In paediatrics, ID consult, as we've discussed previously, not mandatory for HITH admission, but there is a dedicated OPAT team, including paediatrics, paediatric ID and gen medics, but they provide input at nursing handover on daily at weekdays. And they were able to show that by forming a dedicated team, they reduced line-related complications and unplanned readmission. Telehealth was mentioned briefly. At one stage, when I first started at Royal Perth, it was actually a nurse-led service, and there was allegedly clinical governance by the patients who would refer into the team, by the clinicians who would refer into the team. But in fact, the nurses were really running solo. So one of the things we implemented at Royal Perth was for ID to assume medical governance and the hand nurses became HIF nurses, and there had to be acceptance by both clinicians before patients were accepted onto the program. Telehealth has taken off a little bit slower than other states, I believe. I think Queensland in particular has a lot of telehealth. And the other thing to mention is, as I said, Silver Chain looks after metro patients, but does not go outside the metropolitan catchment. Northern Territory, just briefly, in Darwin, fair bit of Indigenous catchment, and specialist nurses, ID physicians and registrars for bone and joint infection, and remote patients could stay in hospital accommodation or via out in their community clinics. Infusers managed by HIF nurses, weekly review at outpatients by the HIF team, and infusers were sent every 1 to 2 weeks in insulated containers via light aircraft. Tasmania, this is personal communication from Duncan Mackenzie. They've got an ambulatory care clinic run by an ID consultant, daily or less frequently clinics. ID maintains governance. Patients reviewed weekly, medically, daily by nurses. Paediatrics generally managed in the same way, but maybe joint care with paediatrics, and CF is managed separately. And nursing care has been outsourced to community nursing care as well. And private patients also get referred into the ACC. So, just to finish off with a few controversies. So, as I said, we tried to make the name a bit more inclusive to sort of so that people who were particularly wedded to HIF models and OPAT models, we wanted to just try and be a bit more all-encompassing. We do make reference to the site and method of administration will vary between home, clinic, aged care according to patient wishes, ED, dialysis centres, GPs, but it will be most commonly at home, and usually, notwithstanding in certain populations in particular, self-administration, usually administered by a visiting clinician, which is usually a HIF nurse or similar. Governance, we wanted to really make sure, emphasise that clear and transparent medical responsibility must be established. Doesn't really matter who this is by, but obviously infectious diseases are extremely well placed to follow antimicrobial stewardship principles, particularly in terms of directed therapy, IV to oral switch where appropriate, and duration of antibiotics. And telehealth is becoming more common, particularly in rural and remote areas. I'm sure this has been mentioned previously, and again, apologies for missing some of this discussion, but the type of parenteral access is very important. And Tony's question about midlines is interesting because we've been grappling with the whole midline thing, and I think your approach with if something's not appropriate for peripheral, then midline is not necessarily going to be a better option. Though if you look in the literature, midlines are described up to being used up to 14 to 28 days. So obviously patient factors, CF, more likely to, there was an interesting CF paper that showed that, I don't think it was Australian, but showed that CF patients were obviously better at managing their lines, and so the recommendation for these patients, or in fact the practice in this study was actually that they were only changing the lines when they became blocked or unusable, rather than a scheduled 72-hour change, which is what would normally be recommended. And certainly there's discussion of this in the Cochrane review in 2015, which seems to imply that a PRN change of lines it may be indicated in some cases. The other thing to mention about PICC lines, obviously renal patients need fistulae and should get tunnelled CVCs instead of PICCs. And the other thing about the other route of administration, we've also got intermittent injection, continuous infusion, again related to the PK/PD of the drug itself. But we are going to include an option, and the French are very, very keen on this, giving subcutaneous ertapenem if IV access is just simply not possible. And it's given exactly the same way as in by a slow infusion. Nursing care, I've already alluded to this. In hospital, HIF or outsourced, rural HIF may have both. Usually once daily visits for cost and resource reasons, though some services will offer twice daily if required. And I have to be a bit careful here, but we actually preferred our HIF nurses. That's all I'll say. First dose of antimicrobials in hospital versus outside the hospital. I don't think it really matters as long as it's in a supervised setting. But if there and the patient, the healthcare professional has training in anaphylaxis plus the appropriate equipment. But if there is a history of significant allergy, it's a good idea for the first IV dose to be in hospital. Indications and patients. There were a lot of discussion in the expert group about what sort of indications were and were not appropriate for HIF, OPAT, COPAT. Pneumonia was one of them. Pyelonephritis was another. I think the thought was that patients, if they're stable, they should be on oral antibiotics. But certainly the literature is full of pneumonia and pyelonephritis treatment, and pyelo particularly in children. I put IVDU. Clinical stability is obviously the paramount thing here. IVDU, we take, if we didn't take IVDU, we would hardly have any IDAC patients. So says a lot about Meth Town, doesn't it? Antibiotic stability, I believe this has been covered very well. Obviously, limited data. We've got this whole in-house stability data that the companies such as Baxter and who's the other one, Slade, won't ever give you. Tony's paper about what is the correct temperature to assess at, especially in the Australian summer. Do you refrigerate? Do you test at room temperature, or is there an elevated on-body temperature? As Tony says, we've used many of these agents successfully prior to stability and toxicity returns being being raised, and despite limited data. The BSAC 95% stability goal at 32 degrees, and there's a lot of mention of Lawrence Manning's paper in the recent BSAC publication. And Lawrence's approach is pragmatic. His view, as Tony has said, by the time the drug's going into the patient, so by the time there's this sort of 87% stability or the 13% is lost, a lot has already gone into the patient anyway. because that's over a 24-hour period. This pyridine degradation thing, I've got no idea what to make of this, but I noticed there's a very recent review paper by some South Australians which say, ignore it, I think. And look, these are some of the others that we use in COPAT. Cefepime, high doses, 12 grams a day of cefoxitin for abscessus patients. Ceftriaxone, you can give us once daily, 4 grams. Tigecycline is allegedly stable, again from Baxter. But we've used it a number of times. It's normally salvage therapy. So, in conclusion, I think that as long as there's appropriate patient selection and there's clear medical governance, which is defined, clear structure, and we're most importantly following antimicrobial stewardship, the name and the exact model of what we're doing don't matter. But I agree that further clarity over antibiotic stability in infusers is needed. Thank you.